Hi, Dr. Issa. Hi, everyone. My name is Joe Safson. I'm the Executive Vice President of MedAxiom Ventures. And I wanted to bring a story to you today about Prairie Cardiovascular and how they have adapted not only prior to COVID, but during and then post-COVID, their use of ambulatory monitoring for cardiac arrhythmias. I think it's a great story. And joining me today to tell that story from Prairie Cardiovascular is Dr. Issa. Dr. Issa, how about an
Hello.
introduction from you?
Hello, everyone. This is Dr. Issa. I'm a cardiac electrophysiologist. I joined Prairie Cardiovascular in Springfield, Illinois in 2005 and have been with the same group all those years. We grew up the EP program at Prairie. We're now 10 electrophysiologists covering a wide geographic area, mostly rural and suburban areas in central and southern Illinois. We're a part of 70 plus cardiologists in total. Our motto at Prairie is to reach out to patients, not to get the patient to us. Those who cannot come to us, we go to them with our coverage over almost 40 plus counties in Illinois. We have to extend our reach to patients in small towns and cities, patients who have to drive otherwise 2 to 3 hours to get to the nearest cardiology office or hospital. So we adapted in early on to get our reach to patients wherever they are.
That is probably a part that makes this story so intriguing, because the practice has built itself a culture of trying to be where the patient is and trying to meet patient need where the patient is. So I think that's excellent. I think that's what makes this a really fun story to tell today. And to dive kind of right in, one of the things that has obviously happened due to COVID and due to the stay-at-home orders that were issued by the government, but we still need to provide medical care because patients continue to get sick. And so most practices had to really either cancel or change the way that they did the ambulatory monitoring for arrhythmias during COVID-19. It was a time for re-innovation. How did you and Prairie monitor your cardiac arrhythmia patients that weren't able to come into the office?
So at Prairie, we started early, a few years ago, of owning our own cardiac telemetry services, outpatient monitoring. And that enabled us to extend our services to patients even who are not able to come to our offices. The model that we have, we buy the devices. We contracted with Preventis to deliver MCT monitors, and we ship those devices. We created certain set of instructions and videos, and usually most of our patients are savvy enough to be able to mount the device and put it on their own. And we have an 800 number that they can call for support. Now, we know our patients, so patients who cannot do it themselves, we get them to our offices, but 90+% of our patients are able to attach the device to the right spot in their chest and start the telemetry recording. Those devices are, even before COVID, have been mailed to patients, so we don't require patients to come to our offices. Especially with the wide geographic area, it's inconvenient to patients anyway. And then we start acquiring the data come to our department here, who will receive the data, notify physicians. Physician will have access to the notification rhythm strips, but also access to the raw data that we can look at in details. We have the ability to readjust the notification criteria according to patients' specific and individual arrhythmia concern. And also, we have 2 layers of eyes on the data, so physicians are not notified unless they really need to be notified. This is a dynamic process. It helped us acquire a lot of data for each patient and a lot of patients, which the volume of services we've been delivering is really growing fast. But we were able to manage this data set. When COVID started, we noticed more demand on the service. Now we're doing virtual clinic visits, and patients are not coming to offices anyway, but we have the infrastructure set already to mail those devices to monitor patients so they don't have to travel or get out of their houses. They get it, then they get it back to us in mail. More and more, the hospitals now are facing problems with either not enough monitors available for their own patients, or if they were providing MCT monitors, they don't have the hardware to give patients to go home with. Also, many hospitals and healthcare systems starting furloughing part of their employees. So even the cardiovascular department in each hospital is less staffed, and their ability to meet the demand of these services has been really impeded lately. So Prairie stepped in to help several of the hospitals provide those services to their patients who are going to be going home. That we send them the monitor so the hospital does not have to worry about arranging that. I know we have ability, but our hospitals were not overwhelmed so far to that degree. We have ability to use outpatient telemetry services for inpatients if we needed to, if the telemetry beds are occupied by COVID patients or others. We have that redundancy, so we can help with that. We did not get to that level in our region here in Illinois.
Wow. So I heard so much there, but what I really took away from that, what meant something to me is that you've got complete control over that process, over sending devices, the hookup. My guess is you could also get some assistance with that hookup if required, that you can monitor, that you keep the data. My guess is you also could have some assistance on the monitoring at off hours and things of that nature as well. So there seems like while you have support, you also have full control.
Yeah, and that service is a dynamic that the support we get from Preventus. So we can customize it. And for example, if we have a couple of our staff are sick and we cannot keep up, we can have Preventus kind of help us with analyzing data and on as needed from our side. So we don't have a long wait time, and that happened on a couple of occasions, whether it's for a few weeks or a month or two. So we have that kind of backup support from Preventus whenever our staffing, if a couple of staff are sick or they change jobs, we're not in a big hole that we cannot deal with the volume.
So that again, that dynamic nature is critical, I think. And so again, I think it's a fantastic partnership for you. One of the things, having this much control, I like to say, as they used to say, the proof is in the pudding, right? But the truth is, as I look at this, what I want to know is, as you have progressed pre-COVID and then through COVID, one of the things that we have seen across the nation is a drop in volume. If I can't get to you, if I can't get a monitor on you, here we are coming out of COVID, you can come in for a monitor, but in terms of more advanced procedures, ablations, insertion of ICDs and pacers, at this point, we see some of that dropped volume. That eventually will catch up. Can you tell me how this has helped you during this challenging time with patients who needed prescriptions? Has your pipeline increased, decreased drastically, stayed the same? What does that look like with this capability?
So the volume across the nation has dropped. Some of it is involuntary because systems want to hold elective procedures in the hospitals. And also many clinics have closed because of concern of COVID early on. And it was a little lag to switch to virtual telemedicine. What helped us is virtual telemedicine to us, especially in the cardiac arrhythmia arena. Most of the most important element other than the patient's story is his heart rhythm, and that helped us even during COVID, even during the virtual health. That helped us still get to diagnose patients and figure out their arrhythmic problem and get the data that's informative for us to make decisions and recommendations. Many virtual visits may not be enough to reach that level of diagnostic and decision-making level if they're not coupled with investigative testing. For arrhythmia, usually documentation of heart rhythm is the most important aspect, and the ability to have the infrastructure that we're able to send the patient the monitor in mail, and we tell him during that tele health visit that our plan is this, and we give him some idea of what to expect with the monitor. Then we contact him again and follow up once we get the data. That kept the volume of patient engagement consistent, and the volume of patient procedures who might be deferred a little bit, but still there's influx of patient procedure indications that gonna be waiting. So although some patients have been waiting before COVID when their procedures were canceled or postponed, but there's still a steady influx through the COVID area of new patients with new indications who would need the procedures.
So the pipeline more or less stayed full, and you were able to continue to help diagnose, so you can go to the next step as soon as the what we'll call it the ban, if you will, on elective procedures has lifted. You have patients that can get the care they need sooner than they otherwise would have. And that's a huge benefit for patient care.
That's correct. And in some programs, although they might have, once COVID restrictions lifted, they might have a bolus of procedures that can be probably even more than their capacity. But there's an air pocket where a few weeks there is no new pipeline patients coming because of cancellation of clinics, primary care or EP and cardiology, and also cancellation of many investigative and diagnostic testings. For us, that kept on during COVID. And it's not just to maintain the pipeline, it helped us avoid delaying diagnosis and treatment. That helped us initiate treatment. It made the virtual visits more meaningful. Not just getting a patient story and then tell them, okay, once we can get you here, we'll do this test or that. No, it made it really more fruitful.
Yeah, well, I think that's right. You're continuing to provide care with good data from afar, and that is immensely valuable. So let me ask you this. As we look, today past COVID, right, and we're all trying to create the new normal, and what is this going to look like? What would be the most important capabilities that exist in your current technology and the remote ambulatory platform? So taking a look at the devices plus the software and analysis from maybe a clinical, an operational, and a financial perspective, how do you take a look at that from all three angles, clinical, operational, and financial?
So from those devices come in patches with different types of patches to accommodate patient's preference. Those patches are now, patient can wear them for 5 days without changing them. They can shower with them, swim, and sleep with them. Patient's satisfaction with the types of patches were very good. The patient will have a small smartphone also. We will call the patient and make sure that they have the Wi-Fi connection, and if they don't, we give them a device with a service, whether AT&T or Sprint, that is better reception in their area. We have many patients in remote areas and rural areas, so we have to be attentive to that. Once the patient get the device, we immediately make the test and it starts acquiring data. And once the data arrives, it's ours. Notification, it takes no delay whatsoever. If there is an important thing, it's within minutes, gets to the physician desk during daytime hours, or if it is emergent, the physician is called and he's emailed a link that linked him immediately to the data that the rhythm strips themselves, so he doesn't have to log on a computer or go to a fax or an email to receive those. And the physician will respond to that. Then once the whole data is collected, our technicians will sort through the data and make it tabulated in a meaningful way to generate a report. That part, we trained our technicians very well to make sure what matters to the EP physician. What do I want to see? And that's really proved to be very important for us. It's just yesterday I had a patient with a different company who had an atrial fibrillation, and he's so young. I was wondering that he have SVT first, or from a WPW kind of abnormality that would trigger the atrial fibrillation, and that's meaningful for us to distinguish between those. And until now, I'm trying to get the onset of the arrhythmia, and all I get is whatever the technician in that company will give me, a snapshot of few seconds or 30 seconds or 1 minute, which is really not very meaningful to me. For us, our technicians will know exactly what the physicians need, and if for certain patients, individualized patients, that we need something different, I email them, can you get me the onset of the arrhythmia or the offset of the arrhythmia? Or we can log on and get to the raw data in our computer or our iPhone and get exactly to what we need to look for in those rhythm strips. Our physicians used to use the device for 4 weeks at a time. Then we taught him to customize this to the need of patients. So if you're looking for certain symptoms and you have symptoms 3-4 times within a week, you may not need to extend the device. And it's the other way. If you prescribe a device for 2 weeks and patient did not have symptoms you're looking for, and you can extend it without getting the device back and without having the patient come back for that service. So even that is dynamic process. Initially, we started with 30 devices for our group. Then we, over the last 3 years, expanded on demand the capacity, and now we have 500 devices that we use, and we still in need for about 900 more because we have a kind of a wait time for the device at this point. On average, we use the device twice a month. That's the average duration, because most of our patients on average get monitoring between 1 week and 3 weeks. There are patients who will get it for one month or longer, and patient gets it shorter. If we get our answer back from them monitoring, we just stop the duration. We don't have to continue with that. From a financial standpoint, I came to know when we were interviewing several vendors that there is the professional and technical fees, and a lot of the reimbursement for telemonitor MCTs goes to data analysis. So our technicians in our department, if they put the monitor on the patient and send him home, our department will gain less than 100, if not just $50 or $30 for that technical fee. And the rest goes to the service company who manages the data and builds the report. By us acquiring the service, that reimbursement changed, and on average for each device, the global reimbursement is in the range of $500, $550. And for private insurance, that ranges between $1,000 and $2,000 reimbursement. That's a huge difference for our department. It used to be an overhead department, and now it's a revenue generating department. It's far, the profit margin far exceeds any other department here.
And I think it's important, not because this is a revenue generating strategy. It is a patient care strategy. And I think you've made that abundantly clear, but there's only in today's environment so many revenue losing patient care strategies we can accommodate in our programs and stay afloat to provide the care that we do. So when you find something that approves from an operational perspective, a control perspective, a good partnership perspective, better delivery of care perspective, oh, and by the way, it does generate revenue in today's environment, to me, that checks all the boxes. So it's nice to hear that's been your experience.
And not just that, I mean, revenue generating will make your plans go far when you present it to hospitals and administrators. Many times, that's what limits any technology that will you think for your department it's going to improve patient service and satisfaction and physician and provider satisfaction. Many times, usually it comes at a price that especially in this time of age, hospitals and healthcare systems are not willing or not able to go that extra yard. But when all this comes with a financial benefit to the system, that makes it easy to acquire and adopt.
I think that's right. There's a case for everybody, and most importantly, a case for the patient. And so,
yeah.
Dr. Issa, thank you so much for sharing the story. I really appreciate the depth that you've gone into. I think it's provided a full picture of what's possible in terms of improving device clinic operations, and just appreciate you cutting some time out of your schedule to meet with us today. So thank you very much. We've greatly enjoyed, I've greatly enjoyed talking to you, and at MedAxiom, we've enjoyed being able to host you for this conversation. And we look forward to seeing you again soon at a MedAxiom meeting.
Thank you very much. My pleasure.
Thanks, everybody. Thank you for joining us as well, and we look forward to seeing you soon. Bye-bye.